webinar presented by MS Auckland. Our guest speaker is Dr. Benson Chen, consultant neurologist at Auckland Hospital and senior research fellow at the University of Auckland. He is going to tell us a little bit about the visual issues in MS. Thank you, Dr. Chen, for joining us, and thank you for your expertise and for your time.
Well, thank you so much, and it's a pleasure to be back and wonderful opportunity to be able to talk about visual issues in MS. Essentially, this evening's webinar is a sort of part 2 of a talk that I did end of last year, which focused on optic neuritis in MS, but I think there is quite a lot of interest in talking about visual issues in general in multiple sclerosis. So we decided a second webinar just talking about visual issues in general would be probably helpful for the MS community. So for the talk this evening, we'll focus on a couple of things. Firstly, we'll do an overview about how we see and the roles and functions of the eyes, the optic nerve, and the brain. And then we'll talk about what sorts of visual issues occur in multiple sclerosis. And then finally, we'll spend some time talking about some of the common visual problems in multiple sclerosis and how they can be managed. So to begin with, often I think it's helpful to think about how the anatomy works and how, what's involved in the process of seeing. So essentially, the best way to think about the eye is to consider the eye like a camera. So like a camera, light passes through an aperture or a pupil, and then the light then gets focused onto the film or the retina where the image is captured. And so if you consider the eye as a camera, there's many instances where the camera, if it's not working properly, can result in problems with vision. So for example, we've got a couple of images here. If the pupil is very small and not enough light goes through, potentially you'll have problems with exposure and focus. If you've got problems with the lens and the lens is dirty, or you've got something on the surface of the camera, potentially this can also cause blurry spots in the vision as well. And this can also cause visual symptoms too. But the camera or the eyes is only one half of the equation. The best kinds of cameras work essentially by taking the photograph, and for digital cameras, the message is then transmitted through a cable to the computer, where the computer can process the visual information and we can start to make sense of it. And our visual system essentially works in the same way. The eyes are the same as the camera. The cable is represented here by the optic nerve. And finally, the visual cortex and the association visual areas are really important for helping us make sense of what we're seeing and to process all the different various things in our visual environment and how we interact with them. So if we consider the brain as the computer, all visual information that's coming from the eyes first reaches the primary visual cortex at the back of the brain. The primary visual cortex receives information, it segments it into various streams, and it integrates the visual information. And it can divide up the visual information along several sort of segments, including lines, edges, orientation, color, and spatial frequency. So the easiest way to think about the primary visual cortex is to consider it as a computer where essentially pixels of information are coming into the brain. And from there, information then gets sent through to two pathways, a dorsal stream and a ventral stream, to then make sense of what all these pixels mean. So the ventral stream is really important for object recognition and form representation. So if we put all the pixels together and orient them in the right way, potentially an image will form. And here you can see a painting of a fruit basket with grapes and apples and some pineapples and things. But then also our brain is really important, that if we flip the image around the right way, things such as faces can be sort of viewed, through this painting as well. And that's simply because the information that's being processed along the ventral stream is being put together and helping us recognize what form these sort of lines and shapes represent. The dorsal stream, on the other hand, is really important for guidance of actions related to vision and recognizing where objects are in space. So for example, here you can see this person juggling tennis balls, and so their dorsal stream involving the parietal lobe essentially is processing that movement of vision and guiding their hands to know where things are in space and what to do with them. But of course, we have two eyes. And so here you can see the role of the eyes is essentially to bring visual information onto the fovea, which is the sharpest part of our vision. And so to coordinate eye movements, there are multiple pathways involved. But most importantly, the pathways involve the brainstem, where a lot of the functions of the muscles, well, the functions of eye movements arise in this region. So putting this all together, we can really summarize to say that over 50% of the brain is involved in vision, either through the processing of visual information coming through or through positioning and movements of eyes to get that visual information into the brain. So let's go through some cases. We've got a first case here of a 38-year-old man who presents with double vision when looking to the left. He's got a right facial droop, and he's also got mild left-sided arm and leg weakness. And in this little video here, we can see that when the man is looking to the left, the eye here on the left side moves to the left, but the right eye fails to move to the left. And as a result, this left eye also has some twitching or shaking, or what we call nystagmus as well. So his examination revealed this finding, which we call a internuclear ophthalmoplegia, or an INO, and his MRI revealed demyelination involving the pons. So this patient was treated with IV steroids. His symptoms resolved, but his double vision recurs whenever he goes running. So the main point here to point out is that in order to see clearly, the eyes must be aligned whichever direction we look, because if they're not aligned, potentially we'll experience double vision, which is a major symptom of MS. Here's a second case of a 45-year-old woman who was diagnosed with multiple sclerosis 15 years ago. She presents with blurred vision, which is worse when she's tired, and she's been told that her eyes shake. And so here's a video here. And so when she's looking straight ahead, you can see that the eyes make these sort of jumpy or fidgety movements from side to side. And an MRI showed that she had high burden of demyelinating lesions, again involving the brainstem, but also the cerebellum, the balance part of the brain. And her pendular nystagmus, which is the description for these kinds of movements that she's making with her eyes, improved after she was started on gabapentin. So the main learning point here is that in order for us to see clearly, the eyes must be kept still without involuntary movements. So involuntary movements are also known as nystagmus, of which there are several types that are observed in people affected by multiple sclerosis. So thinking about what are the visual issues that might occur in MS, essentially here's a big list of things that I think we talked about last time, but it's important to recognize that some of the visual issues that occur in MS are related to MS lesions, some are related to the eyes, and certainly some are related to treatments that patients with multiple sclerosis are on. And some of these treatments may be things that, we take for pain, for nerve pain, but the side effects is that potentially they can cause problems with dry eyes. Or as we talked about in last year's webinar, some disease-modifying treatments such as fingolimod can potentially also cause changes in the back of the eyes that affect vision as well. So how common are visual issues in people with multiple sclerosis? In 2022, a study came out by Van der Veen and colleagues who surveyed 493 people with MS in the Netherlands using a questionnaire called Screening Visual Complications Questionnaire, which is essentially a 21-question questionnaire that's designed to elicit or look for visual symptoms that might cause problems in terms of day-to-day function. And in their study of 493 patients, they found that visual symptoms were frequent. And they compared the results to people who are healthy, so healthy controls. And you can see here in black the proportion of people with visual symptoms reporting often or always having problems, and the hashed lines here represent healthy controls. And so you can see here, in the ones that I've highlighted, these are the ones that were significantly different between groups. So people with MS tended to complain of problems with trouble focusing, issues with depth perception, shaky or jerky vision, problems with their visual field, problems with color vision, problems with reduced contrast, being blinded by bright light, needing more light, having issues with light and dark adaptation, as well as symptoms of dry eyes, needing more time to do things because of their vision, having difficulty navigating or driving because of their vision, and also having issues looking for things because their vision isn't working as well. When they surveyed their patients, this study found that 90% of people with MS experienced at least one complaint, and 23% of patients experienced at least 10 complaints. And the ones that caused the most problems and were more common in people with MS, 50 to 55% of people with MS reported difficulties with unclear vision, trouble focusing, and being blinded by bright light. So I guess the question then becomes, well, are these visual symptoms simply because all of these people with MS experienced optic neuritis, which is a very common form of, very common manifestation of multiple sclerosis? Interestingly, most of the complaints were equally present in people who had a history of optic neuritis versus people who didn't have a history of optic neuritis but still had MS. And so this little chart here compares people who had a history of optic neuritis in black and people who had MS but didn't have a history of optic neuritis in gray. And they found that problems with color vision, visual field, depth perception, and needing more time tended to be reported more frequently in people with a history of optic neuritis. However, compared to people who didn't have a history of optic neuritis, people with, MS and a history of optic neuritis still also had a higher total number of visual complaints, with more discomfort in daily life and a higher number of complaints. So what this essentially means is if you're someone with a history of MS and you've also had a history of optic neuritis, you're more likely to have visual complaints. But also, even if you didn't have a history of optic neuritis and you still have MS, you're also likely to experience visual problems as well. And some of the ones that perhaps are more important in people who haven't had a history of optic neuritis include problems with depth perception, visual field and color vision, and certainly needing more time as well, have been highlighted, but these tend to be much more common in people with a history of optic neuritis too. So I guess the question then comes, well, why does MS cause visual issues? And hopefully, with the first couple of slides, understanding that because over 50% of the brain is involved in vision, any lesions involving the visual pathways or the pathways involved in the control of eye movements or stabilizing vision can potentially cause visual symptoms in people with MS. But obviously, we shouldn't forget that some of the symptoms might be related to the eye. So problems affecting the eyes can also happen, things like dry eyes, cataract, glaucoma, macular degeneration, and also important to recognize that some of the visual symptoms that occur in MS can be related to treatment as well. So let's move on to managing visual issues in MS. So as I mentioned earlier, most common visual problems of MS include optic neuritis, double vision, and nystagmus. And we've sort of presented 3 of these cases. And if you experience visual symptoms as part of a relapse of multiple sclerosis, like other relapse symptoms, we generally expect that vision will often recover, either partially or fully. Steroid treatment can help to speed up the rate of recovery, but not all symptoms require treatment with steroids. So we know that with optic neuritis, treatment with steroids speeds up the rate of recovery, but if your vision is only mildly affected to begin with, steroid treatment doesn't make the visual recovery any better than if you didn't receive steroid treatment. Likewise, if you've also got problems with double vision, where where the images are only very closely separated, potentially you may not require steroid treatment, as over time the symptoms will gradually improve over the course of several weeks. Also very important to remember that steroids can have ocular side effects. So even though we like to use steroids in treating relapses of multiple sclerosis, frequent use of steroids can also cause problems with vision, including issues with raising the pressure inside the eyeball, potentially leading to risk of developing glaucoma. But also if you're using steroids frequently, there's also increased risk of forming cataracts, which can affect vision as well. In some patients, use of high-dose steroids can also lead to buildup of fluid in the back of the eyes and the retina, a condition also known as central serous retinopathy, which can cause blurred vision in the central part of your vision, which may not necessarily resolve on its own. So how do we manage double vision? So double vision caused by multiple sclerosis, if it's an issue with the eyes not moving in sync or in coordination, the easiest way to remove double vision is to simply patch or occlude one eye. So if you block up an eye or close a single eye, that will resolve the double vision. We would expect that over the course of a couple of weeks, potentially no more than a month, double vision will gradually resolve. But for some people, if you're finding it very difficult to function on a day-to-day basis with just a single eye, potentially fogging the lens or fogging the glasses by making one lens blurry means that you can still have your peripheral vision, but you may not notice the double vision as much. In some patients, if the double vision does not fully resolve on its own, potentially we can use special prisms or lenses that you can put onto glasses where it bends light and potentially reduces the severity of the double vision. But Fresnel prisms only work depending on which direction you're looking at. So if the correction that you have with your Fresnel prisms works best for you when you're looking straight ahead, looking to the sides or looking up and looking down, you're likely to still experience double vision, and that may be troubling for some people as well. How do we manage nystagmus? Unfortunately, the treatments for nystagmus aren't as effective. For most patients, we can use medications such as gabapentin or other medications to help reduce the severity of the nystagmus. So that's the shaking of the eyes. And for most patients, if the vision is shaky, we can try and improve visual acuity or the clarity of vision with things like contact lenses or glasses to boost the vision that you have. So when your eyes shake or when your eyes move, the vision is still as clear as we can get it. In some patients with nystagmus, they may find that there's a certain position where they can move their eyes, where the shaking of the eyes isn't as severe. So in this little cartoon here, you can see this child is looking to the left and they've turned their head to the right. And in this picture, essentially this child, when they've got their head in this position, they're finding that the nystagmus isn't as bad or the nystagmus isn't as big. And so moving their eyes into a null point may potentially be helpful in reducing the symptoms of nystagmus. So if you don't have nystagmus or double vision, what can we do about the other symptoms that we've talked about? So in terms of general advice, I would encourage you all to consider having an annual eye exam with your optometrist to look for common eye problems. So remember, common eye problems can potentially cause visual symptoms, and it may not necessarily be due to MS. And a good optometrist will be able to help diagnose things such as dry eyes, or look for evidence of raised intraocular pressure or eye pressure, or even look for signs of early cataracts. As we covered in the previous webinar, unfortunately, after optic neuritis, where the back of the optic nerve, or sorry, where the back of the eyes, the optic nerve, and the pathway connecting the eyes to the brain is no longer functioning as well, glasses and updated glasses won't boost the vision. However, if you haven't had an updated prescription, it may be worthwhile getting your vision checked again, as potentially updated glasses will boost the vision that you do have. For patients who are getting glasses, I would strongly recommend separate glasses for distance and reading, as often wearing bifocals or varifocal lenses can cause more issues in terms of depth perception and balance, and can make it very tricky to function on a day-to-day basis if you've got major issues with nystagmus or double vision. As we talked about, a lot of patients with MS experience glare and light sensitivity, and these can be managed with sunglasses or special filter lenses, such as the FL41 lenses, and adopting simple precautions such as turning on the blue light filter or night mode on your electronic devices to avoid that sharp white light. And so in this picture here, we can see that example of special lenses, polarized lenses here, where its glare has been removed, whereas if the glasses weren't polarized here, you can see that everything becomes very, very bright and sharp, which can be very uncomfortable. And this picture here is just to remind us again that correcting or updating the lenses really only helps with the front of the eyes, or essentially the refraction. It doesn't necessarily help with problems going on in the back of the eyes. And the other sort of important point to remember is if you do wear glasses, do keep your glasses and the lenses clean, as dirty lenses can result in blurred vision. Let's move on and talk a little bit about contrast vision. So contrast vision is the ability to tell between an object that you're seeing, an item that you're seeing, and the background that it's on. If something's low contrast, for example, this picture on the left here of this little white Scotty dog in the snow, it becomes very difficult to find the dog. Whereas if you've got high contrast, where this dog has a black colored coat and on the white background, it's much easier to see. So abnormal contrast vision and night vision can be a major problem in people with multiple sclerosis. And to help with this, I'd really encourage you to think about having bright, even lighting and also using high contrast mode on your electronic devices. So here's another example of what that means. So here in the top panel, you can see something that's low contrast with small font, which makes it very difficult to see. But if you've got something that is high contrast with large font, so for example, black font, black lettering on this yellow background, it's much easier to see as well. And so if you're someone that's experiencing issues with contrast vision, adapting your electronic devices with these sorts of settings can be very, very useful as well. On a different note, it's really important to mention that pseudo-relapses are common, and pseudo-relapses of visual symptoms are very common in people with MS, and often people will experience visual symptoms that can last for hours to days. And it's really important to emphasize that if the vision does fluctuate like this, it doesn't mean that you're having another relapse of multiple sclerosis. More likely, temporary worsening might be related to things like infection, stress, or fatigue. And the analogy here is to think about the neurons as wires, and MS essentially is a disorder where the insulation around the wire, the myelin, has become stripped away by the immune system. So if there's a lot of demyelination in the brain already, and the wires are sending the message from the eyes to the brain, and you become unwell or you overheat or there's other things going on, it can take a lot longer for that message to travel through from the eyes to the brain. And that can potentially cause problems with visual symptoms. And here, the important thing to recognize is that you may be experiencing a pseudo relapse, and to try and address the underlying things that might be contributing to your symptoms. So if you're feeling tired, important to recognize that you're tired and to have a rest. If you're dehydrated, have some fluids, and avoid hot showers and very high temperatures, as these potentially can cause fluctuations in vision as well. The final point I'll make is to briefly talk about managing dry eyes disease in multiple sclerosis. So as you saw from the slides that I presented earlier, dry eyes and symptoms of dry eyes are very common in people with multiple sclerosis. And we understand that there's an increased prevalence of dry eye disease and multiple sclerosis due to neurological dysfunction, autonomic dysregulation, inflammation, and medication side effects. So dry eyes disease is very common even in people who don't have multiple sclerosis, and it's a condition where the tear film, which is the layer that sits in front of the eyes, which consists of several layers, including lipids, aqueous layer, and a mucus layer, essentially the production of the tear film is inadequate. And instead of providing a nice smooth surface for light to come in, the tear film can become very patchy and it can dry out. The reasons for this are varied. In neurological dysfunction related to MS, production of tear film can be impaired by dysfunction of some of the cranial nerves, for example, the trigeminal nerve and the facial nerve, and also issues with medications can be a problem as well, particularly medications that we use for nerve pain can cause the surface of the eyes to dry out. So, what are the symptoms of dry eyes? And most of these will sound very familiar, even for people who don't have MS. Symptoms of dry eyes can include blurred vision, eye strain, a feeling of dryness or grittiness on the surface of the eyes, burning, especially if you're closing your eyes and blinking. Often people will also complain of light sensitivity and glare. And people can sometimes experience reflex tearing. So here, the eyes essentially start to become very watery and produce a lot of tears, not because it's a problem with making too much tears, but because the brain and the body are trying to overcompensate and essentially produce enough tears to help treat the dry eyes. Understandably, if you're experiencing issues with blurred vision, eye strain, and glare, this can potentially lead to problems with headaches and migraines, which are also very common in people with multiple sclerosis. So, how can we manage dry eyes? So, I'd all really encourage you to think about using artificial tears if you've got any of these symptoms. Artificial tears you can purchase over the counter without a prescription, and I'd encourage you to use preservative-free artificial tears or eye lubricants and use them regularly, so at least 2 to 3 times a day. A good analogy I give to my patients is that treating dry eyes is like treating dry skin. If you've got dry skin, we're encouraged to moisturize regularly to keep the skin moist and supple, and it's the same with dry eyes. If you're only using the artificial tears every time you have symptoms of dry eyes, you're likely to continue having dry eyes. Whereas to prevent dry eyes from developing and to also treat the symptoms, it's very important to use artificial tears and lubricants regularly. In some patients, they may have a concurrent problem called meibomian gland dysfunction, where the special oil glands around the eyelids don't work properly, and as a result, you get buildup of oil and sort of crusting around the eyes. And so if you're noticing that the eyes are very sticky or that you're waking up with a lot of crusting around the eyes in the morning, it's really important to try using warm compress. So have a warm flannel and essentially warm damp flannel and clean around the eyelids, and that will help to open up the glands so that the glands are producing oil, which will contribute to the tear film. If you're someone who's working in an office or working in an environment where it's very dry or there's a lot of air conditioning, it's also really helpful to think about having a humidifier. And especially as we're heading towards the winter months where people will often have heaters on during the day, the room can become very dry, and this can cause further issues with dry eye symptoms. The other really interesting thing to note is that with frequent use of electronic devices, such as looking at computer screens or monitors, there's lots of good studies that show our rate of blinking actually reduces when we're looking at the computer. So I'd all really encourage you to limit the amount of screen time that you use and adopt the 20-20-20 rule. And so what this is every 20 minutes, look away at the computer screen for at least 6 meters away or 20 feet away for at least 20 seconds to allow your eyes to sort of adapt to looking at a different distance, and then try to focus on blinking regularly as well to help with the symptoms of dry eyes. So, in summary, there's many neural pathways that are involved in vision. MS can present with optic neuritis, diplopia or double vision, and nystagmus, which is involuntary eye movements. But even if you didn't have a history of optic neuritis, visual symptoms are very common in people with multiple sclerosis. We haven't talked about the treatment and management of optic neuritis, but if you're interested in understanding more about management of optic neuritis, I'd encourage you to look at the recorded webinar, which is on the MS Auckland website. But with regards to the management of other symptoms, really important to think about optimizing and enhancing vision using glasses and environmental adaptations, and also really important to think about promoting good eye health, including prevention of things such as dry eyes disease, which seems to be very prevalent in people with multiple sclerosis. So with that, I'll end there and say thank you for your attention, and we're happy to take questions.
Thank you, Dr. Chen. It's been really, really interesting. Yeah, we sometimes don't realize the connection that is in between the vision problems and the MS, and quite often, these vision problems are, yeah, yeah, people try to find some other causes, but yeah, it was just amazing. Thank you so much, and sure, happy to take questions. So please type your questions in the Q&A box. So the first question is, what is the best health professional to see for nystagmus issues?
Yep. So to help with nystagmus issues, I think it's really important to, well, two people that potentially you can go to, your neurologist or someone who has an interest in problems with the eyes can be very useful. And even if they don't, even if they aren't able to sort of make a clear diagnosis or provide specific advice, certainly they can look at using medications. And there's a lot of useful guidelines that are available to us as medical professionals. But certainly, I think the most helpful people to sort of have a review with if you've got nystagmus and concerns with symptoms is to actually see an ophthalmologist, and specifically either a neuro-ophthalmologist, so someone who's got specific training in neurological problems that affect vision, or a strabismus surgeon, so someone who's got interest and expertise in managing problems with alignment of the eyes and with eye movements. So often the strabismus specialist, they may start off with using specific medications, or they may ask you to see a neuro-ophthalmologist to begin with. But certainly if there are, if you continue to have symptoms, even with, medications, and potentially if there's something surgical that can be offered, the only person that can really offer the surgical treatments would be the strabismus surgeon or the strabismus specialist.
Thank you so much. So there is a surgical option to correct some of these issues?
Yes, there can be a surgical option. Unfortunately, most of the surgical options that are available can be quite aggressive. And by that, I mean, if the eyes are shaking like this, then sometimes potentially what you can do is try and paralyze some of the muscles by using Botox injections into the eyes so that the muscles become a little bit weaker. But usually the most effective management for nystagmus, if you're going to offer something surgically, would be most appropriate for someone who's got a null point. So for example, if my nystagmus is really bad when I'm looking straight ahead like this, but if I turn my eyes that way, and the nystagmus isn't as big, most patients will tend to turn their head and look to the side like that to get their eyes into that position. So what a strabismus surgeon can then do is to tighten the muscles around the eyes to pull the eyes in that direction so that you don't have to walk around with your head turned to the side all the time. So it may not be an appropriate treatment for most people, but in some patients where the nystagmus can be a massive issue, if there is a null point, then potentially a strabismus surgeon will be able to help with that.
That's fascinating. Thank you. Uh, Next question. Is there anything that can help with nystagmus and travel sickness in the car?
Yeah, so that's another very common symptom as well. A little bit beyond the scope of tonight's talk, but the
Okay.
reason why a lot of people can experience issues with nausea or travel sickness, especially with motion, there are two possible reasons. One possible reason is that it's not necessarily a visual issue, but it's a problem with the balance and the vestibular parts of the brain. And maybe we'll think about doing another webinar about balance and dizziness because it's a very common symptom as well. If it is a visual problem, often patients with MS who notice that they experience a lot of nausea or they experience a lot of sort of discomfort, especially in visually stimulating environments. So, for example, being in a supermarket where you've got the aisles and lots of colors and lines, it can feel very uncomfortable. That is essentially a problem where visual perception and processing of information has become an issue as a result of the multiple sclerosis. So the approach that we manage these sorts of symptoms is as well. There's several approaches. Often we can use medications such as anti-nausea medications to help treat the nausea, but long term it's not a really helpful treatment. The best treatment in terms of trying to come off and being less reliant on these sorts of medications is to potentially go through a period of vestibular rehabilitation, where essentially you're teaching the brain and the eyes to work together so that if you're moving your head really quickly and the eyes aren't moving as quickly with the head, potentially you can start to retrain some of that function back, but also being comfortable with having lots of visual stimulus and being, in those very sort of visually stimulating environments as well. So again, similar to nystagmus, we can start off with medications, but ultimately going through a period of vestibular rehab or even physiotherapy can be very useful for symptoms like that.
That's very helpful, and I think it answers to the next question that's about vestibular physios. So they definitely help with us. This,
Yeah, most definitely. Yeah, so vestibular exercises can be really useful for problems with coordinating eye movement. So one of the really common symptoms, if you've had, MS causing a relapse in the balance and the vestibular parts of the brain, often if you move your head very quickly or turn very quickly, people will notice that, for that brief couple of seconds, that suddenly they feel a little bit nauseated and they feel a bit sick. And the natural tendency is to obviously to avoid doing those movements. And the problem there becomes that if you're not moving your head or you're avoiding those sorts of movements, that can really cause issues with creating further nausea and further symptoms. So actually vestibular rehabilitation are helping with habituation, where you teach your brain to be comfortable in moving in those certain positions, will be really helpful in the long-term management of some of these symptoms.
thank you so much. And the next question is, should people who have had early optic neuritis issues expect for that event to reoccur? Will DMS options help specifically with optic neuritis?
Yeah, so another really good question, and maybe I think covered a little bit better in the previous webinar, but the disease-modifying treatments that are available essentially work for all types of relapses. None of the disease-modifying treatments are specifically better targeting for optic neuritis. And the reason for that is the optic nerve itself is essentially a projection of the brain. It's got the same neurons, it's essentially the same tissue as brain, even though it's found at the back of the eyes. So if you've had optic neuritis, I think it's really important to, first of all, confirm whether or not you've actually had optic neuritis. As
Yeah.
we covered in the last webinar, optic neuritis is a diagnosis that's often made in excess. So what that basically means is because traditionally optic neuritis has been a diagnosis made clinically on the basis of the symptoms that someone presents with, often people who've been diagnosed with optic neuritis, and I think it's less common here in New Zealand, but certainly in the US where I did my fellowship, a lot of people are diagnosed with optic neuritis that actually didn't have optic neuritis. They may have had actually a migraine with a visual aura, or they may have had sort of, other symptoms that were not related to optic neuritis at all. So to answer the first part of the question, I think it's really important to, number one, clarify if the diagnosis of optic neuritis was correct. Number two, if the diagnosis was correct, and actually there are other clinical signs and imaging signs that indicate that actually, yes, there is multiple sclerosis, it's really important to get on to disease modifying treatment. And previously, I think, the diagnostic criteria for multiple sclerosis meant that the optic nerve itself didn't actually count as a sort of site of a relapse or somewhere that could be involved on the brain scan. But I think the updated diagnostic criteria, which is yet to be published but coming out soon, the optic nerve is back in again. So optic neuritis, really common, really important, and really important to get onto disease modifying treatment if the diagnosis is indeed MS.
Yeah. Thank you so much. And we have another interesting question. Who is the best person to see to get a diagnosis for optic neuritis, an optometrist or an ophthalmologist?
Yeah, so have a look at the previous webinar again, but essentially in last time's talk, I think, the suggestion was to use your optometrist basically like you would use your GP. So someone you can go to for your first question about problems with the eyes. I think most GPs won't be comfortable at all managing sort of optic neuritis or suspected optic neuritis. So I think, if you're someone who has a diagnosis of MS already, if you've got issues with your vision, first person to see would be optometrist, and they can do the initial checks and do the assessments that they can. Often, if the vision is sort of reduced with the visual acuity, so if your reading ability has gone down, or if they make you do the visual field test, so the computer game where you hit the button every time you see the light, and it becomes clear that there's a visual field problem, or if the optometrist is suspicious about optic neuritis, then usually they'll refer you on to the ophthalmologist, who will then sort of review the situation and consider whether or not they think you've got optic neuritis and arrange further investigation. Again, the problem, I think, similar with the previous questions, optic neuritis is a very common diagnosis and not something that's always made, a diagnosis that's made accurately. So I think, if you've got concerns about the diagnosis of optic neuritis, either you think you've been misdiagnosed, or you think that you've actually had optic neuritis or you've got optic neuritis, but the diagnosis hasn't been made correctly. I think the best person to see after you've seen an optometrist or an ophthalmologist is to ask to see a neuro-ophthalmologist. So neuro-ophthalmologists are subspecialists such as myself, either with a background in neurology or a background in ophthalmology, but we've got a special interest in neurological problems that can affect vision. And obviously multiple sclerosis is one of these major issues and major things that we deal with. So if you've got concerns after seeing your optometrist or ophthalmologist, ask to see a neuro-ophthalmologist, and there's several around the country, and actually several in Auckland, including myself.
That's great news. It seems that's the end of the questions. Really interesting questions indeed, and amazing presentation, Dr. Chen. Thank you so much for tonight.